Can we get a mic? Okay, good morning, everybody. While we put the mic on our last panelist, I feel like things are a little bit on the last day here. Everybody's trickling in, so I'd like everybody to stand up, please. Put your coffee cups down, everybody stand up. Come on, up we get, everybody up, wake up. Okay, so turn to somebody next to you, and I want one of you to close your fist. So my name's Angus Thomson. I work with Irimi company. Irimi is a Japanese word. It comes from a martial art that I practiced for many, many years in Japan. I'd like you to turn to the person next to you. One of you close your fist, and the other one just has to open the fist. Just open the person's fist. Come on, let's go. Turn to somebody. Not two fists. One of you hold the fist closed, and you just have to open. There's a technique here that you might find.
You ready?
Yeah?
Just one.
Yeah.
Just one fist. Just that. I have to open. You cannot let me.
Okay, stop. Okay, Julie, please. Shh. Everybody, okay. Okay, close your fist. I'm going to show you how this works, okay? Come on, close your fist. Keep it really tight.
Me?
Yeah. Okay, you ready? Could you open your fist for me?
Actually, I'll use my left hand because I'm left-handed.
Could you open your fist for me, Julie?
No, this is a game.
Okay, every training I ever give that works except with Julie. I use that in many trainings with health professionals and health promotion officers, etc. And I haven't yet seen someone just try to communicate to the other person. Could you open your fist? You can sit down again. Good morning, everybody. Bonjour. Pour les francophones, je suis désolé, on a imaginé peut-être de faire tout ça en français, mais pour deux raisons, j'ai décidé de ne pas le faire. Un, c'est parce que vous allez souffrir avec mon accent pendant 1h30. Et deux, tous les anglophones vont prendre 1 heure pour mettre les petits trucs pour la traduction. Donc, on va faire en anglais aujourd'hui. We're going to do the session in English today. Si vous voulez poser des questions en français, aucun problème. Et évidemment, vous avez des traducteurs aujourd'hui. Merci beaucoup, les traducteurs. So, welcome today. Sawadee krap. I'm absolutely thrilled to be here. This is like, you couldn't pay me to do this. This is as good as it gets. I like to think, I'm imagining today that this is going to be a fireside chat, although that seems rather inappropriate in Thailand, doesn't it? So perhaps it's like a food stall chat. We're all sitting on plastic chairs on the street and just talking about a subject that we've all been thinking about a lot, and we've been studying and we've been dealing with in our practice every day. I'd like to start by introducing the panel, but let me just reiterate the topic of today's session, because it's a biggie. So, the challenges of online and offline circulating misinformation relating to zero-dose children and new vaccine introduction. So we could probably spend all day, but we've only got an hour and a half. It's important, I think, to begin with an introduction of our speakers, because I've got a fantastic panel today, absolutely packed full of expertise and experience. To my left, I have Dr. Adidja Amani from Cameroon. Bonjour.
Bonjour.
Dr. Amani is a public health specialist, a vaccinologist, lecturer and researcher. At the start of the pandemic, she was director of vaccination in the Ministry of Public Health of Cameroon, but she moved fairly quickly to the WHO, and in her current role, she's been leading the technical support for the global COVID-19 vaccine delivery partnership, the COVIDP, in 5 countries: Kenya, Le Gabon, Central African Republic, Côte d'Ivoire, and Cameroon. She's been responsible for coordinating vaccine distribution, getting people vaccinated, getting people to get vaccinated, and fostering collaboration with the country teams. And I imagine overcoming many challenges over the last 2 years. Previously, she was program manager for Africa at the international NGO Site Savers, and she has been API manager in Cameroon. Thank you very much for joining us.
Thank you. Director of Vaccination.
Director of Vaccination. My apologies. Next is Ana Bottallo from Brazil, from São Paulo. Anna's a biologist with a PhD in zoology and paleontology. She reports on science and health for the publication Folha de São Paulo since 2020. So, in the last couple of years, she publishes on environment, science and health, but she's been rather busy with the COVID-19 pandemic, as we all have, I suspect. She's got over 600 articles published to her name. She's received many accolades for her work, as indeed has Dr. Amani, as indeed has every member of my panel, so I may not repeat that again. And she's currently engaged as a publisher of a health newsletter called MVDDc from Folha de São Paulo. Next, going along, is Dr. Farah Qamar from Pakistan. Dr. Qamar is a clinician and a researcher in pediatric infectious diseases who brings, I think, a 360-degree vision of vaccines and vaccination. She has more than 100 peer-reviewed publications, and her current research includes assessment of the efficacy, effectiveness, and impact of the typhoid conjugate vaccine, which has been newly introduced in Pakistan and which we may hear more about today. But obviously, as a clinician, she's also dealt with vaccine-preventable diseases in clinical settings and witnessed its impact on individuals, the impact of these diseases on individuals and families in communities with poor support systems, and understands, I think, with first-hand experience, the strengths and limitations of our vaccination programs. Don't think I need the notes. Julie Leask, my last panelist. Julie is a fellow Australian. She's professor and social scientist specialising in immunisation at the School of Public Health at the University of Sydney in Australia. She's a member of the Sydney Institute for Infectious Diseases and a visiting fellow at the Australian National Centre for Immunisation Research and Surveillance, NCIRS. She has qualifications in public health, in nursing and in midwifery. And her research that I've followed very closely from the very beginning of my time working in this field focuses on the behavioural and social aspects of vaccination and risk communication. She was the chair of the, as you may have heard in earlier sessions, of the WHO-UNICEF Best Behavioural and Social Drivers of Vaccination Working Group, and she sits on advisory groups for the WHO, for UNICEF, and for the Australian national and state governments. My name's Angus Thomson. I've been working in vaccine acceptance and uptake for about 15 years now, close. And in the last few years, supporting the demand team at UNICEF, a lot of my work's been focused on misinformation. So today we're going to be talking about misinformation, but I'd like to just set the scene and challenge perhaps a couple of assumptions, as I want to do, because I think this is an area that's too important for us to be working from supposition and assumptions. But if you would allow me, since I've got the stage and I'm in front of a room full of researchers on this subject, I'd just like to underscore the importance of our work and the importance of your work for two reasons. One is, without the research you're doing, we wouldn't be able to design and implement effective interventions. But our challenge, the challenge I feel like we face, that we face across the world, is not vaccine acceptance. It's under-vaccination. It's under-vaccination. And the second crucial role for your research is to help ensure that we do not fall into this dogma of people are under-vaccinated because they're hesitant or because they're refusing vaccination. So please bear in mind that you are also responsible for building equity in securing solutions to this problem that do not scapegoat the very people that we're meant to be serving. And thank you all for your research. Let me flip to the subject now. So I just want to start with a couple of caveats. I've been given 10 minutes to introduce. Most of the talking is going to be done by my panelists, but I'd just like to set the scene, as I said, puncture perhaps a few assumptions that I'm sure none of you have, but that we have to deal with on a daily basis. First of all, misinformation is not about hashtag misinformation, okay? It's about the communication ecosystem that people find themselves in and from which they seek, or in which they seek and find the information that they need to make their decisions. So it's about an ecosystem that each community lives in that may have gaps in the information that they need. It's about an ecosystem in which people are expressing questions and concerns. And of course being exposed to misinformation. But it's not just about misinformation. It's a problem that we have, but our responsibility as researchers and practitioners is to understand that context that every person finds themselves in. And indeed, something that's come up in this meeting over and over that I really like is it's also about the priorities of people. And people are seeking information versus to support or to help them with their personal priorities. And vaccines aren't always the first priority of everybody. Secondly, it's not about social media. It's not about social media. It's not about social media. There's a lot going on there, and we have tools that allow us to track it. But conversations on vaccines, about vaccines, are ongoing. Offline, radio, television, other channels, and on the ground, in communities. And so, for me, it's about social listening that enables us to be listening into all of those conversations, and of course track the misinformation as well, the misinformation online, offline, and on the ground. And my last caveat is that there's no point in thinking about misinformation and studying misinformation and understanding that ecosystem that people find themselves in if we are not coupling what we are hearing with the work that's happening in the field, the risk communication, community engagement, social mobilization. Social listening must be coupled with the actions in the field, and that happens not through dashboards, but through smart people who are listening and analyzing what's being heard and providing actionable insights to the people in the field who don't have the time to digest and think through things. And so it's about humans at the center of that pivot point between the listening and the action. So today, I thought we would come at this in two directions. First of all, I think it's important to understand the problem, as I've already discussed, a little better, and then with the experience and the expertise that we have, to start thinking about what's working and to leave you, hopefully, with some very concrete examples, insights into what can be done to tackle misinformation, but also to provide people with their information needs in communities around the world. Welcome, panel. It's over to you now. You won't be hearing much from me. Let's start with the problem as it relates to zero-dose children. And Julie, could I ask you to help us set the scene? Where are we up to? What is the context that we should be thinking about in terms of the impact of misinformation, the effect of misinformation in communities with zero-dose children?
So first of all, thank you, Angus, for your introduction, and it's wonderful to be here and to the organisers for this amazing meeting. And it's lovely to see VAN moving along in this way. It's such important work. And I also just want to do a quick thank you to our translators who work incredibly hard to make sure that the information is accessible to people speaking French. So a big shout out to you guys too. So we heard on day one about what is related to zero-dose children. So zero-dose children are more likely to live 3 or more hours away from a health facility, to live in urban slums, and to be affected by conflict and displacement. So that's the bigger picture that we have to acknowledge and address. But I think, we were having a conversation about this beforehand, and you planted a bit of a seed in my mind, which is well, aren't they more susceptible to misinformation if they're not getting access to the healthcare system? And I think you're right. I think it makes a lot of sense, although it is an empirical question and some of you will be sitting on data that answers that question. But if a family don't have good access to a healthcare service, to the information, the resilience building, and the relationships that give that foundation of trust in that system, in that expert system, if you like, then they are going to be more susceptible to misinformation. But I think we need to be fairly careful with our assumptions about just how linear this is, because, you know, think of media theory, this old idea, we called it the hypodermic model, where people used to say information goes out to a community and they just accept that information, it changes their behaviour as if they're a blank slate. And that discourse turned to, it's not what information does to people, it's what people do with information in the context of their beliefs, values and experiences. So as you say, it is an ecosystem and we need to think about misinformation. You know, it's different analogies, it's coals and a fire, it's an iceberg with what's on the surface and what's on below, or it's the idea of the seed in the soil. And a seed will take root, misinformation takes root in a soil of poor treatment, injustice, racism, bereavement, trauma, all these other bigger picture things. So I think, you know, that's a bit of a waffly answer, but it does say that misinformation is about the community and their own resilience to its effects, and it's definitely not linear.
Thank you, Julie. And yeah, the coal's melting the icebergs. Adidja, if we can just, because we've got a big topic today, we can just pivot and we're going to oscillate back and forth between zero dose and new vaccine introduction. You had an example of, well, it's not a new vaccine introduction, but the introduction of a vaccine to manage an outbreak in Cameroon, a cholera outbreak. I was wondering if you could just provide us with a short overview of what happened to give us a kind of a snapshot of the importance of misinformation within our response to an outbreak, or of course, new vaccine introduction.
Okay. Thank you, Angus. Maybe before starting, I would like to extend my sincere appreciation to the Sabin Institute for the invitation, to UNICEF, and for the COVID vaccine delivery partnership who asked me to represent them here. So, yes, I think you are referring to my experience when I was Director of Vaccination in the Ministry of Health of Cameroon. When when the first case of coronavirus was announced in the country, we were supposed to have a mass polio campaign, but the minister halted, everything was stopped. We had to stop the campaign, no campaign, nothing. We needed to observe the situation. But in between, we had a cholera outbreak, multiple outbreaks across the country. But this was so spectacular, visible. You cannot say, no, we stop, we don't do anything. We had to do a mass vaccination campaign, right, to stop this outbreak. So just at the start of the pandemic, and we did not know much about COVID-19, but we had to do something. So because people were dying, and we seem to have forgotten like the best practices, like we need to communicate like 1 month in advance, and we did not really have this time because we were in the middle of a cholera outbreak. And this is counterintuitive because at the time we were washing the hands, you know, everybody was learning to washing the hands and taking all the hygienic measures, but it happened. So we went into the cities into the district where we had the outbreak. Unfortunately, it was not a very good campaign because the little of communication that we did in the 3 days preceding the campaign, most of the people, when we were saying cholera, they were understanding corona. So this information, this word came across like, oh, they want to inoculate corona to us. So people will close their door. I mean, the OCV, I mean, it's the easiest vaccine to administer. You just drink it. But it was catastrophic. People will send even their dogs to our teams, the vaccinators, throw us WhatsApp, please go away with your corona. This is a way for the government to get the population contaminated. So it was, the coverage was really low, 50% overall, really the worst mass vaccination campaign we ever did. And this was because of this misinformation. And I'm not getting to the solution, but for the second round, learning from that, I think we put in place some measure. We started communicating 1 month in advance. We put in place several strategies, and we moved from 50% to 86%. And this study is actually published in the Vaccines Journal. So, yeah.
Thank you. And I think we'll definitely in the second part of our conversation come back to what are the things that work, and preparation is going to be an emerging theme, I'm sure. Perhaps just to continue to add a bit of colour to this conversation, a conversation that could become too colourful, misinformation, disinformation. I don't want to spend the day, the morning talking about definitions, etc. But I do think that there's an important definition, and we can discuss the nuances later. But there's an important distinction between mis and disinformation, and disinformation is deliberately engineered, carefully engineered misinformation, engineered to get people's attention, to be spread, and it's usually employed through deceitful tactics and with malign intention. People have, and that's an important distinction. However, we want to get into the nuance. Anna, you had a number of extraordinary experiences as a journalist in Brazil during the pandemic, including a president who was a fan or indeed a source of disinformation and who was supported with that work. Could you describe in a few minutes what was going on?
Yes, of course. So I think that first Brazil was an example of successful vaccination program worldwide. We had very high coverage of vaccines of routine immunization. And so everybody thought that when the COVID pandemic started, we were going to be ready because we have more than 30,000 facilities to vaccinate people all around the country. But that wasn't what really happened, because when the COVID pandemic began, our former president, Jair Bolsonaro, he was working with the virus, not against it. So everything he would say in public television or he would say in press conferences was to minimize the disease, to minimize the virus, to say it's a Chinese conspiracy, or that people would be transformed into crocodilos or would have implantation of microchips with the vaccines. So all this talk, of course it's absurd, nobody turns into a crocodile, but people really, that puts people into fear, that destroys the confidence that people had with vaccines in Brazil. And it was a very high confidence. So in Brazil, we would see, when we had flu outbreaks, queues that would go around the corner for people to get the vaccines in the private service, whereas we have it in the public service for all. They would pay to get the vaccines because nobody wants to get sick in Brazil. That's how our national program of immunization was important during the last 2 decades. But then we also saw a beginning of low coverage of vaccination in 2015, 2016, and it plummeted with the COVID pandemic. Because when people don't have access to the healthcare centers, and during the pandemic, a lot of people were saying, you should stay home, you should not take your child to immunization because you could risk getting the COVID. So people were very confused of what types of messages they would have to listen. And then the presidents, the former president, discuss and his words on the pandemic really affected people's trust in our vaccination program and in our health program. I think that as absurd as it can look, when we talk about these phrases that he has come out to say, that really had an impact in people's beliefs, because when they are not able to access the information, or they are not able to access the healthcare facility centers to get vaccinated, or they have concerns about their health or their children's health, this sort of message puts, as Julie said, plants a small seed. And this seed, it could be harmless at the beginning, but it can grow to be something that puts in perspective routine vaccination, which was never questioned before. And just to finish my intervention here, I think that for me, what was the most transforming experience was to cover the COVID as it was rolling out. So we had first the deaths and cases, and then we had the development of vaccines, and we were reporting that all the time, all throughout, on a daily basis. And people were looking very closely to the vaccine development, as in a way that nobody has ever looked before. So we started talking about efficacy in clinical trials, and these were a lot of different information that people couldn't absorb, because nobody has ever talked about efficacy or clinical trials, or how vaccines work, or if this technology is an mRNA vaccine, or this one is an adenovirus vaccine. So it's a lot of information that people has never been given before. And when we take that information that is very difficult to access, and we have somebody that says, you are not going to use that vaccine in your children because that could lead to side effects, or this could lead to, I don't know, maybe some reaction in the former years that you don't know yet. So people are scared. And since they didn't get that information before, that information from authorities that were that they trusted, they feel, I think they feel a little hesitancy. I think that's the word, hesitancy. Not totally towards misinformation, but hesitancy. So that's what affected most. And we had a drop in vaccination coverage throughout the pandemic, so since 2019. And Brazil is one of the countries that's the vaccine hesitancy has grown, and we didn't have that before. So we had 99% acceptance, and now we have 89% acceptance. Of course, 89% is still good, but if you think 10% drop in 3 years, it's a lot.
Yeah, thank you. So, yeah, I mean, there's one point you made that I've been thinking about. It's a little bit kind of be careful what you wish for. I feel like there have been many outcomes of the pandemic. On the one hand, none of this is new to us. We've been dealing with misinformation and many of the challenges that we've had for decades and decades, ever since we've had vaccination programs. But yeah, be careful what you wish for, because there is definitely a heightened public awareness of vaccines and vaccination, which we must be capitalizing upon, but which also makes our work even more important. We're close to transitioning to what we need to be thinking about in terms of addressing this problem. I want to make one other definition that's really helped me in my work before I ask you a question, Farah. And that is, we talk a lot about trust, which is great. I think that so much of what we study comes back to this. But there's a concept of trustworthiness, which I think is important just to set a baseline. And trustworthiness describes the qualities of the people and the organizations that we get our information from, that we will use in our decisions, that we will use to build our knowledge, because of course we can't know everything. And it's about expertise, and it's about credibility, of course, but it's also about concern and benevolence. Okay, we listen to the people that we think have our best interests at heart. And I'd like you to hold on to that concept, because I think it's fundamental for many of the solutions that we need or should be developing. Farah, perhaps you could just add a little bit more colour to the context, to the impact of our vision of the impact of misinformation. We're talking briefly before the session about underserved communities in Pakistan who are particularly susceptible, and also the potentially dire consequences of that. And then I'll ask you to start to perhaps transition to the solution or the approach that you think is needed to start to address that, which I think will lead us into part 2 of our discussion, please.
Thank you, Angus. So listening to all other colleagues, like you said, Brazil is a place where people have low vaccine hesitancy, but this Pakistan is in sharp contrast to all of these countries. We have a persistent and ongoing problem of vaccine hesitancy and poor confidence in vaccines. And that is one of the reasons that polio is still not eradicated in the country. It's one of the countries where wild polio virus is still persisting. And there is so much misinformation that is persisting in the communities regarding this old disease. People are talking about the new oral cholera vaccine and COVID vaccine, but we are still fighting the challenge of polio and to improve the coverage of polio vaccine. So and the misinformation, it spreads very quickly in the communities. So in the northern parts of the community in particular, northern parts of Pakistan in particular, which are the populations that are the most illiterate, have poverty, living in slums, have political conflicts, problem of Afghan refugees coming in. So together with all of this, the problem of misinformation regarding polio vaccine, the commonest being that the OPV causes sterility in males, and so that has led to killing of many of the polio workers, which is extremely saddening that these vaccinators are going door to door in a temperature of 45 to 50 degrees, the hot summers, and they knock on their doors and they just get killed because they are there to give you your child and protect your child from polio and give the drops to your child. So in these communities, there are physicians, and physicians are the most trusted voice in most communities and most countries, family physicians and GPs. And these are the people who can contribute here. But the problem is twofold, that physicians have their own priorities. They have busy clinics and they may not have the time, and they may not have the effective tools to communicate and dispel all of this misinformation that is circulating in the communities. And it has been shown even in Pakistan that physicians are the people who can convert the vaccine-resistant people and guide them if they spend the time and talk to them and are able to answer their queries. But that never happens. So this is an area we need to focus on. And later during the talk, I will share the example of how we changed this with the introduction of the new vaccine, because physicians, regarding the vaccine, they are not given the tools, they are not trained in communication, they themselves at times may not have updated knowledge about the vaccine, and there also is a problem of quacks in these communities. So they take a lesser fee, they are not certified, and they have a false sort of trust within the communities. And they want to maintain this false trust. And because they are charging less fee, and most of the poor are likely to go to them, and these quacks do not want to lose their money and don't want to lose their patients. So many a times they would just continue to support the misinformation that is circulating in the communities. Okay, you're right, what you're saying. So because they want to keep their practice going. So there are two facets. So certified professionals are not trained and do not have the time, and those who are quacks, they have their own benefit. They see their own benefits in continuing to support what their patients and the people coming to them are saying.
Thank you. Out of mind, out of sight. I forgot to introduce Dr. Joe Smizer, who was meant to be with us, but who had a very high fever 3 days ago, was swabbed, and turns out he has influenza, so he stayed in the US. Joe is CEO of the Public Good Projects, a not-for-profit in the US that's been doing social listening for the US CDC, for public health departments across the US, and in collaboration with UNICEF across the world during the pandemic. I don't think today will be talking much about social listening, but I want to just plant the seed in your minds that the solutions that we're going to start to talk about are impossible without us having well-organized mechanisms to be listening into the conversations in real time and to be understanding, as I've said, the concerns, the questions, not just the misinformation that's circulating. And those mechanisms must be plugged into not just social media with the nice dashboards and algorithms, but it must be tracking what's going on radio, television, and in communities as well. So I just want to leave that, but with our social listening mechanisms in place, if we are identifying and characterizing, hopefully assessing misinformation narratives that are circulating, the question then is, what do we do? And so, Julie, I'd like to come back to you. And first of all, talk a little bit about what we know as scientists in terms of the response that we should be considering to mis and disinformation. And I think Julie's challenged my assumptions in the last while with research that she's done, because for a long time, I would always have the caveat that we should be careful about what we do, about what we respond to, because in responding to any misinformation narrative that's circulating, we may be, I think it's a word that I got, it's a phrase that I got from you a long time, Julie, a long time ago, putting oxygen to the fire. But I think our understanding's pivoted a little bit. Julie?
Yeah, so the context here is, what do you do about anti-vaccination activism? And the anti-vax groups will put out misinformation and disinformation. And what do you do with it? Well, I think first of all, we need to check our own responses to it, because it can be frustrating and worrying, and sort of dealing with that in the first instance is very helpful. And thinking strategically about what to do. And there has been incredibly helpful research that has changed the way we think about this. And I know John Cook is in the audience, and he put together a fantastic debunking handbook some years ago, which gave some very practical guidance on how to deal with misinformation about climate change. And it was things like, be aware of these particular effects in the way you deal with misinformation. And one of the warnings that we had that was based on a little bit of evidence at the time was that if you deal with something that's wrong by restating it up front, you actually increase people's exposure to it. So, for example, MMR vaccine causes autism, myth. Fact, blah, 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 blah. Lots of technical information about the vaccine and all the testing of the vaccine, and people kind of get lost in all those facts and they just see the myth, and then it makes them more familiar with that myth. So that's the idea of a backfire effect. Here's the cool thing about psychological science, that as evidence has come out around that, and there have been people studying it, Mareike Steffens, Ulrich Becker, John, I think you've published research around this that shows that it's okay to lead on the myth. It's not going to create a backfire effect, but it is actually very important that you address that myth. So if you do want to debunk a myth about vaccines, like the COVID vaccine causes infertility, you can say, how do COVID vaccines affect fertility? Or you could say myth, COVID vaccines cause infertility. But you need to carefully explain why that's not correct, why, according to the best evidence we have, and that's where you're communicating uncertainty, because you need to do that to sustain trust. This is what we know, and there's studies in Israel looking at, IVF clinics and people's sperm and eggs, and, give people a bit of detail. So addressing misinformation is important. But do you do it every single time you see a bit of misinformation? No. You need to think about whether it's affecting people. is it salient? Is it memorable and interesting to the population? Is it going to tap into those deeper anxieties and concerns that the population, the community have? And then respond strategically with addressing the myth rapidly so you don't leave a vacuum, because misinformation loves a vacuum, and using trusted spokespeople to do that.
Yeah, thank you, Julian. We'll get to a few of those points. There's another piece to responding to mis or disinformation, which you're able to hear about, you'll be able to hear about in the next session. So it's, in addition to doing everything that Julie said, highlighting the way people are being tricked, the tactics that are being used, the so-called logical fallacies. So logic-based strategies, and also potentially, I don't think we've really tested them yet, but source-based strategies. So highlighting the malign motivations of the authors of disinformation. So not only are we helping people understand that this is what's true, not that, but that they're being tricked as well, potentially gives us a boost to the effect that we can have. I think we're also going to flip between responding and preparing. So Adidja, back to preparing. So you noted that in the cholera outbreak, you just had to dive in and you weren't well prepared. But throughout the pandemic, you were supporting deployment of the vaccines in 5 countries. What are the things that you saw or that you would give us as the key elements of a plan that prepares in advance for the kinds of outbreaks of misinformation that we might face?
Thank you, Angus. I love the outbreak of misinformation. It's actually a good term. We need to find a good vaccine to misinformation, right? Really, I would like to challenge the audience with this. I would like to share a story. On my way from Addis to Bangkok, I was sitting with a man from South Africa. He's paraplegic, and he's been on a wheelchair for quite some time, 25 years. I mean, I came to find out later because I thought initially it was polio. So we spoke during the entire flight. It was 9 hours, so we really got to know each other. So, and from, conversation after conversation, I learned to believe, I've learned many things, that like he eats chilies every morning to avoid infections and things. So I was like, okay, I would like to know what is his thought about vaccines and vaccination. And he's a wealthy man. He traveled from South Africa to Vietnam, Shanghai. He sells electric cars, so wealthy family. He's a granddad. He has 2 daughters and 4 grandchildren. And he does not believe at all in vaccines. And when I've heard what an educated, wealthy man, who travel around the world, who is supposed to have like the best knowledge, was saying about the vaccine, I was quite disappointed. But what was more heartbreaking was that he has such a powerful influence on his family that he told me that the granddaughters, he has 2 granddaughters and 2 grandsons, they are not vaccinated. I could not believe it. And apparently they live in the UK. I don't know if it's possible to live in the UK without being vaccinated. I don't know. Anyway, so those are zero children, 0 of those children, right? And I was like, if he's able to have this strong influence on his daughter, up to his grandkids not to be vaccinated, so how do we break this cycle where there's this huge family influence? Even in Africa, we had yesterday an experience from Nigeria. A colleague was sharing with us that when you go in the family, the mother-in-law will tell to the granddaughter, if you get your child vaccinated, he will not walk on time. So yes, so please do not vaccinate him. So we have also this aspect of zero-dose children in wealthy family, because the prototype that we have is conflict zone, uneducated mothers, but we also have the opposite. So the solution, as you are asking about the strategy, for me, I think it's a complete paradigm shift. I feel like we invest a lot into undoing what has been already done, the harm that has been done. I would like to challenge the audience to really think about investing in children more, investing in planting a new seed in children. And yesterday, I don't know, for those who were here for the video session, if you are not here, you missed a lot. It was an amazing session. And I think that I've shared the experience where I myself, one of the reasons I chose to be physician is because when I was a child, there was a cartoon that was coming twice per week, and it was about microbes. It was called Microbes. It was about germ science and this, and it really inspired me. So I would really like to challenge our thinking, and I'm also happy that UNICEF is here, and their mandate is really about children, to invest more into having these videos, this information, the right information, going into children, information that will make the difference, so that we'll have the children who will ask their parents, Mom, I'm 10, I'm 12, I need to get my HPV vaccine. And adults that will, automatically take their children to vaccination. So paradigm shift, invest in cartoons, this kind of information directed to children. And I'm happy that, I don't know if Stacy is around, she shared with me that Sabine is already investing in this gamification and this kind of work. So really, I really want you guys to give a big applause to Sabine Institute for thinking already in this way. And yes, for me, this is really the future of, communication. Let's invest in children. Let's plant the right seeds from the beginning, and we'll have to invest less into undoing what we adults, are sometimes very reluctant to do, while this is also quite important. Thank you.
Thank you. Yeah. Let's roll with that. I think that's a really important transition. I'm looking at the time we have. We've got plenty of question time too, so please start thinking of the questions that you'd like to pose to this great audience. You'll get the chance to be in my shoes and ask questions to these folks who have so much expertise and experience. But given the time, we had a number of points. I had a number of points about responding to misinformation, but let's just roll with this transition. So we've got people seek their information, they get their knowledge from trustworthy sources. I'll come to health professionals in a minute, but the media, people seek and find their information with you. So let's actually move ourselves into this new space. So what do we do to start building a healthier communications ecosystem in which we've planted the seeds that have sprouted? It's a nice analogy. I think we're going to stick with this till the end. And indeed, the soil is less fertile for the seeds of misinformation. Wow, I could go on and on with this. Anna, yeah. So we talked a lot about the role of journalists in responding to disinformation, but actually I'd like to challenge you to tell us a little bit about, from your perspective as a health journalist, what's your role, and so what's your role, and what do you need as a journalist from these kinds of people to actually be building that healthier public perception of infectious disease, of responses to infectious disease and vaccines?
Yes, first, Angus, I think that the main problem when we think about the traditional media is that people don't consume it anymore. So it's hard to compete with the environment where there is misinformation, which is in WhatsApp or in Instagram, YouTube. People are getting that information because they consume these types of tools and social media. They don't consume any more newspaper. This is something that I think most of people here never open a in the past few days has not opened a printed newspaper version. So we have to think as media in ways of achieving those people, accessing them. So we have paywall, but for information that's regarding health, we should take that paywall. We should make this information available. Of course, we have public television, radio. These are more accessible ways of communicating. But the problem is that usually when we have TV, radio, we have 30 seconds of to pass the message. Usually it's not as sufficient to get all the information. So first thing I would think is media should specialize, should think outside of the box, should think how to achieve. If they are using a language, if anti-vaxxers use a language that sticks, we should think of the same type of communicating. We should also have our messages sticking to people and making people think, oh, but I read this, I saw this article, I remember that I saw this news piece at the TV. So they should think that the same way as the anti-vaxxers get their message. It should use the same tools. I'm not saying that we should use the kinds of tools that they use, which is conspiracy theory, or maybe they use some psychological tools that get to people's beliefs and concerns, because that's not professional journalism. But we should use the same tools to get the message. First, that's the first thing. Second thing is that I think we should all learn from medical experts and from physicians how to translate the message. So, of course, when we think about new vaccine introductions or new technologies or side effects, or if we can combine these two campaigns together, these are a lot of information for the immunologist. So how do we translate it that it becomes accessible? So Adidja was talking about how we should communicate with children, and I totally agree with that. In Brazil, we had an experience that for the immunization program campaigns to work, they introduced a mascot that's very popular with children. So children will feel they are more comfortable to get their vaccine shots when they look at this character, which is Zé Gotinha.
Do you think it's more effective than a needle?
Pro-effective, yeah, yeah, because they usually have the mascot and they are kind of looking at the other way, and the nurse or health professional is getting their shots. So we should use that kind of approach. We should make people know that this is something they can also take control. It should not be just how can I say? It should not be just imposed to them. We should have them participate. That's the second thing. Translating the message and having people participate. And the third thing is, now I think we are getting into that response thing you said earlier. We should make people know where the information that they got first, the first information that this misinformation or fake news came from. So it's very important to say, you believed in this misinformation, but it's from a group that's profiting from fake news. This is profiting from anti-vaxxers groups. They have political interest. They want to make deputies or candidates for the next election. So people should know that they are not in their interest for their concerns or their health issues. They are there for their own purpose. They are there for their own objectives and to profit. So I think this is the final question.
And that's really a way of undermining people's trust in the disinformation that's coming out. And I think it really is a place where journalists can play a role. And so often I read articles about disinformation, and the disinformation is discussed, the impact of it is discussed, but they don't get to where is it coming from and why is it being produced in the first place. Yes. So sticking with the idea of creating a healthier space within which people can find their information, Farah, health professionals are almost invariably the most trusted voice, if not one of the most trusted voices that people hear. You've been quite active in Pakistan to equip health professionals with what they need to provide that trusted voice more effectively, both in terms of the knowledge they need and the skills that they need. Could you talk a little bit to the work that you've been doing, please?
So, thank you. Yes, so we keep hearing this statement that healthcare professionals are the most trusted voice, but unfortunately for new vaccine introductions, this is the group which is never taken into loop. They are never taken into any of the communication loops that take place whenever a new vaccine is launched into the country. And we tried to change this with the introduction of the typhoid conjugate vaccine. And before I go into the typhoid conjugate vaccine introduction, I'll just share a brief example of the polio vaccine, coming back to it again. Whenever I sit with a GP or a family physician, I make it a point that I discuss one or two small things about vaccines so to understand their knowledge and their perceptions of what, not knowledge, mainly perceptions, what they think and how would they be communicating with their patients. So I asked one of these physicians sitting next to me in somewhere, and I asked, what do you think about the polio supplementary immunization days and the national immunization days? And he said, it's all rubbish. I don't understand why the government is doing it. And this is it's a doctor, he's a family physician, and says just complete the routine immunization and that should be fine. So I tried to convince and then just explain why these are important. But this just reflects how the physicians, they lack the information and the resources that they need for what is being done for immunization services within the country. So for the typhoid conjugate vaccine, we had a big outbreak of a very drug-resistant typhoid. And following that, we had the opportunity to get the policy approval for introduction of that vaccine in the country. The one good thing that was done with the introduction of this campaign was involvement of physicians, the Pakistan Pediatric Association, the medical associations, and creating physician champions. And those people were trained in communications by the UNICEF communications team, by the media team, and any adverse event, any questions, any misinformation, those were the people who went out and resolved those and answered to those queries. On the first day of the vaccination campaign, when the government launched it, there was a big anti-vax group, a religious community, and it was a first time in the country a mass immunization campaign was happening. And that entire group of 15-year-old, they just collapsed receiving the vaccine. And that was just a fake drama, but it was a huge lashback on the campaign because this was just the very first day of the campaign. And then, because these physicians were trained in media, they were trained to communicate, those were the people who were on the forefront, who went out and gave the messages on radio and on television, and that's how we were able to carry on with the campaign, and those things were resolved, and we were able to vaccinate 10 million children in 3 weeks' time. So it was a huge success because of involvement of the physicians.
Thank you. That's a really solid example of the kind of preparation we should be imagining well ahead of any new vaccine introduction. I'd like to open up to the audience. Questions, but also comments. There are 2 microphones there that you can come up to. There's a microphone in each aisle. And please, if possible, keep your questions and comments now focused on the response. What do we do? What have you heard that's working? What do you know that's working? Let's not get too stuck in misinformation and the things that we've seen. But if possible, stay on our response. So I'll oscillate backwards and forwards. Please introduce yourself. Tell us who you are before you ask anything or say anything. And keep it short, please, because we've already got 6 questions and we've only got 30 more minutes and it seems to be ticking out very fast. So let's start over here, please.
Okay. Hello, everyone. I'm Ufeisha Romompo. I live from University of Ibadan, Nigeria. And I want to thank you for the panelists. I'm going to go straight to my point. I want to thank Dr. Amani for bringing in children and adolescents about risk communication and vaccine acceptance. Because in my country, during the heat of COVID-19 pandemic, there were a lot of communication about risk and everything, but we have limited, very limited, for children and adolescents. And it took just one person to produce something online for children and adolescents. So my question is, what will you say about how do we involve children? And I know it's very expensive to produce animations, cartoons, 3Ds, especially for Lemi country like Nigeria. But there are a lot of children too, like, who will not be able to access those things here. And who may not even have access to television, but we still need to communicate this risk to them. So what is your take on this? Thank you.
We are taking on the question.
No, I'd like to go one by one.
Wow. Thank you, Mofe. This is a really tough question and very important as well. Yes, I strongly believe in investing in children, strongly. And for children who do not have access to television, as you said, who do not have access to phone, yeah, social media and all of this, I think that one of the power that we have in Africa is the power of storytelling, right? And I think that this could be the way, and we do that very well. And again, I say I believe in this double strategy. What we are doing now, trying to debunk information in adults that we have, I think this is more of the short, medium term. But I think for the long-term investment, we need to think about children. And I think that storytelling, also investing into having in our communities, people who can relate these beautiful stories around the fireside, I think is a way of going forward for the children. This is what I can say for now. Thank you.
Yes, please.
One example that I can share is that in the poorest communities where we introduced the typhoid vaccine, we developed a nice jingle and we called it the typhoid jingle, and that was played outside schools, within communities, in health camps, and that had a couple of sentences about what the disease is and what campaign is going on and how we can prevent it. So just a brief jingle, and it attracted a lot of children to the camps and to the places where the campaign was going on.
Julie, did you want to answer? And let's keep our answers short because the lines are getting long.
That's very busy. At a global level, have you CSOs that work with youth?
Let's do this. Hello. So involve civil society organisations that work with young people and get the voice of young people into this conversation. At a local level, see if you can work with education to embed vaccination education into the curriculum, whether it be science, personal development. Nice work in Australia around that by people like Rachel Skinner, Kristen Davies, showing that you can also, if you create a good experience around school-based vaccination, you can reduce anxiety about getting the vaccine. And if you don't traumatise young people when they get vaccinated, they are probably more likely to have a vaccine in future and be more comfortable giving their kids vaccines.
Yeah, thank you. Traumatise the kids, but also traumatise the parents. I mean, taking your kid for a vaccination is not always the easiest experience. And quickly, and then from now on, we're going to have one quick response to each question because I'd really love to hear from everybody.
Just to complement the amazing responses we had here, I did a news piece with children to get the COVID vaccine, and they engaged so greatly. So we interviewed a lot of children that were hoping to get the vaccine, to see their friends, to go out on trips, to travel, to see their grandfathers and grandmothers. So I think that when we put them in the front, they also engage and they also help, and they are going to say to their parents, I want to get the vaccine. Because I was in the news paper or in the television saying that I want to see my friends, I'm not scared. There was this little girl that said, I used to cry, but today I'm not going to cry because I'm very happy to get the COVID vaccine to see my friends. So I think putting them also in front.
Yeah, moving them from passive recipients. Exactly. Next question, please.
Thank you. I am Zara Jamil, the Social and Behavior Change Officer for Vaccine Communications in UNICEF Pakistan office. And as Dr. Farah was mentioning, I was the one managing the crisis communication for the TCV campaign and the very recent measles rubella introduction campaign. So, as Dr. Farah said, it was a multi-pronged strategy. We had communications on ground, community engagement, preparing social media influencers, media, journalists, et cetera, so on and so forth. In all of these vaccine introduction campaigns, we did sensitize all the journalists before the campaigns, but at the same time, we had a backup plan of keeping our media PR agency and giving out advertisements to all those media houses to ensure they don't run any negative campaigns. At the same time, when we were tracking, we were doing social listening, tracking social media conversation online for any misinformation. As soon as something erupted, we used our on-ground teams to counter that misinformation by, one, sensitizing those people spreading the misinformation, the ones that blew up, and also at the same time using the hyper-local influencers in those communities to counter that misinformation. So my question is, when you have to decide between saving the trust, saving the campaign, and drawing that fine line between ethics of crisis communications management, how do you draw that line between both to decide whether to go for keep the ethics there in crisis communications management or go save the campaign?
Ooh, who wants to take that one? Go on, Julie.
I'm not sure I fully understood the dilemma, but I'll refer it to dilemmas that we've faced with COVID, for example, where you wanted to be very honest with, so AstraZeneca vaccine and clotting, right, TTS. You wanted to be very upfront and transparent with people at a time when you knew that you might set in train a whole stack of hesitancy. When you're faced between two bad options in crisis communication, go for the one that maximises public trust in the long term. Yeah, that's my answer.
That's a great answer.
Being honest about your communication, I think that will build trustworthiness in the long run.
Thank you.
Thank you very much for the great discussion. My name is Ridwan. I work for UNICEF in East Asia Pacific region. I think there's a lot of discussion that, as I mentioned also earlier in the first day, that one of the things that happen why misinformation spread is because there are, of course, people still trust physicians, but they don't have time, they don't have tools to provide that education. And secondly, of course, one of the very important channel of misinformation or disinformation is social media. We know exactly that the algorithm of social media is the one who pay more, penetrate more. And that's what actually happened. Why? I think that's also being used by anti-vaccines. I want to use this stage with all great minds here, great panels here, to see what happened right now. The growing boost of use of AI. What can we do? How are we going to use or even anticipate that? Because I think we know exactly where we're going. Most of them will be used by many people as a part of information. What can we do to be part of that, to make sure that it did not be used? And then, of course, I think we have a lot of researchers here. I think also I want to use this stage to please provide us with some information how to tackle that, because it's going to be leapfrogging us while we start still trying to address some of the existing challenge for many years ago. They're going to leave us, and then we're going to have another problem. So maybe it's a great comment from panels or anyone will be very useful. Thank you.
Another tough one. Who wants to speak to AI?
Well, I'll start by saying we can harness it to great effects. I mean, you know, and I'm sure you're thinking about this too. If people have questions about vaccination, you can set up a chatbot to help answer their questions. You've just got to make sure that the algorithm is very well trained and and well informed. So I think harnessing technology. It doesn't have to be our enemy. You know, we're always anxious about new technologies. People are anxious about the telephone. But I think we can, you're right. I'm so glad you asked that question because we need to start thinking about this now and we need to talk to and listen to people who have expertise in what AI means for us in immunisation so that we can start to be on the front foot with this thing, but definitely harnessing it to help address questions and concerns.
And I'd echo that. We have to get ahead of this. We didn't get ahead of the the recalibration of algorithms around 2013 and 14, where all of the social platforms just recalibrated them so that they were absolutely 100% seeking people's attention and sharing, whereas before they were serving our interest. They were providing us with interest. We didn't get ahead of that, and our strategies, I think, as you touched upon, have not sufficiently taken that into account when we're engaging on social media. It's not just about paying, it's about understanding how the algorithms work and getting our content out there so that people find it and the algorithms promote it. And I think that also, there's also a piece of this that is engagement with the platforms who use those algorithms to make a lot of money, and a level of accountability for them in terms of not what they publish, but what they promote. Katie?
Hi, Associate Professor Katie Atwell from the University of Western Australia. I'd like to take a few comments from the panel and put them back to you as a very focused question. And so it's with regard to what you referred to, Angus, as the malign motivation of sources of either misinformation and disinformation. And it's about that occurring in the offline space, so particularly looking at what you called quacks. But also we heard yesterday from Guatemala, work Julie and I have done in Australia, shows that people really trust these alternative health providers because that's who they can afford, but perhaps also because that's who they can get the sort of personalised care from. And of course, the challenge, as you very eloquently put it, is they have an economic vested interest in either spreading misinformation or disinformation. Angus, you indicated, and I agree, that we're not really seeing much work in that space, particularly the offline space. So there's been some really good work online looking at how pre-bunking people about the sort of motivations of people spreading information online can come from nefarious interests. How do we do that in the offline space when it's at that very individualised level of my care and I trust this provider, not perhaps the trusted health provider from a Western medicine sense? Thank you.
That's a really great question. Farah, could I pass that to you, because we discussed this a little bit and this is something that you've been facing in many, many communities in Pakistan.
Yes. So this is a problem, a persistent problem in many communities in Pakistan, as I mentioned earlier. But one thing that has been done in COVID and would be helpful in for all other immunizations is compensation and incentivization. So you give the proper tools to all of these, irrespective of whether they are practicing complementary medicine or they are certified physicians. You give them the proper tools, and then based on whatever scheme for compensation you decide, whether it is a monetary compensation, non-monetary compensation, that can be decided on national and regional schemes. But that is something that has proven to be very, very helpful in COVID and what was done in COVID. I am not sure why people don't like the idea of compensating the time for physicians that they spend for counseling or for vaccination. So that's one suggestion.
Should we move on to that?
I think the answer came yesterday, Katie. You pointed to it, the work in Guatemala, which was not seeing the tribal medicine practitioners, or in Australia it's complementary alternative medicine practitioners, as the enemy. Bring them into the fold. Naturopaths. Most of them in Australia, as I understand it, actually support vaccination, but they've been stereotyped as being against vaccination. And so that escalates a war with those practitioners, and we need to bring them in and engage with them. Now, the question then is, how do you scale that up, right? What's sustainable? Do you have your complementary practitioners on your advisory groups? You can get backlash for that as well. So I'm not saying it's easy at a policy and planning level, but it's, let's not create wars where they're not there, and let's engage with those professionals on shared values.
Thank you.
Hi, everyone. Thank you for a really insightful panel. My name is Kemisola Agbaoye. I work with Nigeria Health Watch, and we do a lot of work around managing misinformation using both online and offline social listening. So this has been really insightful for me, so thank you. I wanted to ask a couple of questions. One was around vaccine hesitancy among healthcare workers. We know that, yes, they are the most trusted information source. Most people cite that. Some of our studies have shown that as well. But during the COVID-19 pandemic, we had healthcare workers who were hesitant to take the vaccine. And there are healthcare workers who are also misinformed and who peddle misinformation through their practices. How do you tackle that? Secondly, I wanted to ask about influencers. Julie, you had talked about identifying trusted sources and getting them to pass the misinformation and the debunks out. How do you think about their own perceptions and their own tendencies to be misinformed or vaccine hesitant? And how do you sort of see through that? How do you influence them and turn them into champions? And also your thoughts on whether this is a viable method of passing debunks out. Also about the media.
Two questions. There's a big queue. I'm sorry, but there's a big queue.
Worries.
I have to give everybody an opportunity.
No worries.
And they're great
if
questions.
you could just apply my second question to the media, that would be great.
Well done. Why don't we start with the second and third one first?
So Margie's at that mic, and she'll probably mention this, but Margie and her colleagues have developed a form of peer education and confidence building around vaccine conversations. We work together in Australia in this area, Vaccine Champions, you might have heard of it. There's plenty of efforts to educate communities and to give them confidence around vaccination, but just turning up with a community group, spending a little bit of time to give them information. Our work in Indonesia showed that they don't necessarily have to be really confident in vaccination to get alongside and support vaccination efforts, which was kind of an interesting contra-finding. I know we've said this a lot, working with communities, and it feels like a truism, but I think we've come to a phase in working in vaccination where we're seeing this turn to the community and seeing their importance and centrality in addressing COVID and in addressing misinformation. So if you can shore up a sense of confidence around vaccination, a little bit of knowledge and a confidence to have a vaccine conversation with others in the community, then you will be doing a great service to that community engagement. Same with journos.
Would anyone like to speak to healthcare worker hesitancy?
Maybe.
Something that I just don't think we talk enough about.
Go to the next session.
Go to the next session.
One thing that I heard a lot from experts is that the most part of the healthcare workers, they are not scientifically trained. So I think this is the first thing that could help. So when they understand better the science behind the clinical trials and vaccination development, they also transmit better the message to their patients.
I would say that hesitancy is just one end of the spectrum. Most are vaccine accepting. They do not have the complete information or the complete knowledge. And if given that knowledge and provided all of those evidence, I think they can be very easily converted to vaccine accepting people. And that's true for healthcare physicians and also for the parents.
Margie Danchin from Melbourne, Australia. So I really just want to contribute to this conversation because I think obviously misinformation is what I like to think was a wicked problem. And I'm still very unconvinced about the strategies online to address this effectively. I mean, we talk about AI and there's some really clever games like Cranky Uncle that John, that you've been developing, Angus. I think that there's a lot of opportunity to address misinformation online, but I think the money is in community engagement. And it is like talking about healthcare worker hesitancy and training healthcare workers. I think it's around education, but also really how to have an effective vaccine conversation. And I think those two go together. It's the what. They really do need answers to questions, some basic education about new vaccines. They have questions they want answered. But then they also do need some assistance in how to have an effective conversation. And so vaccine communication training, role-playing, it's so critical, and I don't think we do it enough. I think we sort of talk glibly about training, but what is that? And is it effective? And then secondly, there just aren't enough healthcare workers. We need the community advocates. We need the teachers. We need the faith leaders, the community leaders, trusted members of the community with the same training, education, vaccine communication training. I think it's a really powerful model. It's scalable. It can go into all communities because people trust those people from their own communities. Even if we get really clever online, I don't think people really trust that information. So I think there are powerful examples of how this has been done well, and I think we need to share them and build on them rather than reinventing, different programs. So anyway, come to the vaccine communication Vaccine Champions presentation I'm doing later to talk about this program, which we've now done in the Pacific, in Vietnam. We're hopefully going to be doing it in Indonesia and the Philippines. And I think this sort of community grassroots training of healthcare workers and broad community advocates might really start to cut through on the trust issues in communities.
Thank you. Oh, please.
Hi, everyone.
We've got, sorry, just a second. We've got 9 more minutes, 10 more minutes. I need 1 minute to sum everything up. So you've got 3 minutes each, question plus answer.
Okay. Hi, everyone. My name is Ming, and I'm from Ganesh 8, a public health consulting firm in Vietnam. My background is public health, and my major concern is in the field of health communication. So thank you for the wonderful conversation in terms of misinformation and stuff. And so I would like to pose a question about the role of the governments in the whole circle of information and misinformation. So ideally, we would like the government to spread correct and true information, but sometimes they just spread half-truth. They withhold information or even spread misinformation as well. And this creates a distrust that we can clearly see in the time of crises such as COVID-19. And the problem is this kind of distrust builds up every time people don't trust in the information the government spread out. So and this creates conspiracies among the communities, and it creates further misinformation and disinformation. So I would like you, the panelists, and also the attendees to reflect on your previous experience working with the government or governmental health agency. And my question is, what should be our approach when working with the government in terms of health communications? Thank you.
Adidja, would you like to start?
Okay. Thank you, Angus. Yes, I have worked for the government for 15 years. And with the COVID-19 vaccine, COVID-19 in general, we've seen a distrust in general, particularly around the vaccination, more specifically. So I would like to share the experience that we have within the COVID-19 vaccine delivery partnership. It was a program that was set in place by the UN Secretary General, particularly because we did not see an increase in coverage, particularly in African countries. And one of the things that, of the mandate of the COVID vaccine delivery partnership was political advocacy. And we've seen in multiple countries where the coverage were extremely low, that joint political advocacy efforts. So in the COVID vaccine delivery partnership, the head of the partnership with other partners, multi-agency, UNICEF, WHO, World Bank, humanitarian actors, CSO, will jointly go to a country, and when we go there, we don't target, the technical people. We go at the presidency, prime minister office, the people who have a huge influence on the population. And we've noticed that when there's buy-in, because sometimes even themselves, they do not have the right information, right? And then when we discuss with them and you tell them what is their role, how important is for them to relay the right information and for people to trust them, they get the buy-in. And we've seen that in many countries. In Cameroon, people, I have many colleagues from Cameroon here. We shifted, increased just after the visit of the partnership, high-level visit. We met with the prime minister, we met with top officials, we went on the media. The coverage has increased. We did that in many countries in Africa, from Tanzania, you can name it. So the experience that I can share is really high-level political advocacy. And I think that with the COVID-19 that is phasing, the emergency that is no more there, we need to take this lesson learned into routine immunization. We cannot keep it at low level among us struggling. We need to have this joint high-level political advocacy. Yeah, thank you.
Yeah, just to complement, working on the COVID pandemic with a governor that was against the vaccination or against the disease, he was always telling fake news and misinformation. The media partner, as we had built a consortium in Brazil, so all the media outlets that are usually concurrents, but then work together to get the message to people. So we would do everyday tolls on the number of cases and deaths in Brazil because the government itself was withholding that information. So working together and making people know that what the government is making is misinformation or disinformation. Fact-checking, bringing specialists and scientists in the media to put the counter discourse on what the president was saying, showing them the information, and really working together as media, as with the scientific community. I think this, and also always telling people that this is what's based on evidence. This is what the scientists have now for the most recent information available.
Two more questions.
Hi, thanks for the enriching conversation. My name is Saransh Sharma. I'm from Final Mile Consulting. We are a social and behavior change research company. So firstly, I just want to thank Anna for reinforcing that there is a problem of vaccine hesitancy, because I think there's a healthy terminology debate going on, and I think just by changing terminology, we cannot wish away a problem. There is growing distrust and hesitancy about vaccines in general because of the COVID pandemic. My question is about, how do we make our approach to misinformation more human-centric and user-centric? I'm catching a lot of cues that we see this sort of war happening, that there are scientists and the public health community on one side and anti-vaxxers on the other side, and the people are just passive followers in this war that we have to capture. From understanding human behavior, we know that people are very attuned to social cues about trust and trustworthiness, right? So they are very carefully paying attention to scientists, politicians, researchers. What cues of untrustworthiness has the scientific and public health community given? Not just the politicians. Politicians have, of course, messed it up royally, right? But what lessons will scientists and public health researchers take away about science communication from this crisis? We have done some, just very quickly, we have done some focus group discussions with people specifically about, misinformation. And people are not always listening to anti-vaxxers. they are listening to people on social media who are sharing their personal, individual experiences, right? So this framing of anti-vaxxers versus us is not the complete picture. So yeah, that's the question. What can we learn about communicating better? Thanks.
I come from a family of, you know, my grandmother was against vaccination. She raised my mother to be against vaccination. My mother rebelled. So opposition to vaccination is in our family DNA. I love my family. We don't talk about vaccination. Because people and relationships come first. And we had a lot of, you know, we were doing through COVID emergency phases, we were doing a lot of community education sessions on how to talk with people who won't vaccinate or who are antagonistic. We trained clinicians on how to deal with a situation where someone requests a medical exemption because they need to go to work and they can't get one, and then you have to deal with conflict and you have to use de-escalation skills. It has to have empathy and respect at the heart of it. And the more we've created wars around anti-vax movements, which are real, the greater escalation there is in the conversation, the more, it's not true polarisation, but it's where you get more sort of warring parties. And the audiences to those conversations need to see you hold yourself with dignity, to respect what we were about, which is about the health and well-being of populations, and to keep focused on that ultimate goal. And with that ultimate goal in mind, what is a hesitant person, someone sitting on the fence, how do they need to see leaders behaving? And I think we need to take those sort of principles to the way we have public conversations about vaccination.
Thank you, Julie. Time's up.
Yeah.
So please, I want to respect everyone's time. You've got a very quick question.
I'll respect you because you're all my heroes. And Angus, thanks. I stood for 10 minutes, never for 1 minute. So you are my heroes, all of you here. You are really my heroes. I want to give you a context. I'm coming from New Mewat, India, where a population of 1 million has 1 pediatrician and a very little few health workers. I run a mobile health van which goes to the villages. I have a trust of the community and they will do whatever I tell. For 18 years we have worked there. I believe Julie and again, Adidja, you said the right thing. We need to train children. Immunization is a child's rights issue. It's an essential right of a child. So why don't you have this in the curriculum of primary schools? Not go up to the HPV vaccine. Primary schools, go up. And if you want to send the message, UNCRC is their advocacy document. So health and education, protection, all those issues, right from the curriculums, that's one. Second, you want the response of the pediatricians. I trained in India, the topmost place, the All India Institute of Medical Sciences. I trained in the topmost institute in the US, UCSF, University of California, San Francisco. Nowhere the physicians are actually trained in the social behavioral change communication strategies. They are not even trained how to work effectively with multidisciplinary workers on the front lines. Technology is great, online is great, but what we thought worked very well with us through a small grant from Sabin was engaging with communities through puppet shows, through role models, through peer workers and leaders who actually did Nukkad Natak, which is called theaters, bike rallies, and a one-to-one interaction with the ASHA workers going into the homes. Nothing can replace this. Online and offline, both are needed. Thank you.
Thank you very much. That's a very nice point to finish on. Give me 30 seconds to try to capture a couple of things that I've heard today. First of all, I think you've heard a lot of things that work. So please, let's not reinvent wheels. HCD is absolutely fundamental, but we know now many things that work and should be implemented. HCD is what we do to take the things that are working and make them relevant for the context that we're going to apply them. And only when we don't have a solution in front of us should we be thinking about starting from scratch. The second thing that I've heard is that language is very, very important. The way we frame the problem impacts not only the way that we understand, analyze, and respond to it, but the way others see and hear the problem, and it can in and of itself affect people's attitudes and behaviours. Anti-vax, hesitant. Is that what people are, or are they under-vaccinated, underserved? The war against misinformation. Is it a war? Is it a conflict? Or is it an abject failure of public health to occupy the conversation, to be listening to and speaking to people and responding to their questions and concerns? Nature abhors a vacuum, misinformation loves it. And I think the final thing that I've heard today is we've got to build the choir. It's got to be a big choir. Of course it's got to be health workers. Of course it's got to be governments. Of course it's got to be the media. And we've got to be continuously engaging and providing them with what they need to understand this problem and to be part of the solution. Engaging with the public. They're not passive recipients. And a final note, kids. Why should they be passive recipients? They're the ones being protected. Kids aren't stupid. Should kids be the number one, the frontline voice for us? Thank you very much. Thank you so much, panelists. I could sit in front of this fireside for days and days and continue this conversation. Thank you all for your thoughtful comments, and see you soon. Thank you. Thanks, Anna. Thank you, Farah.
Thank you.
That was great. Thank you, Julie.